All right. Are you ready, sir?
I am ready, yes.
Okay, I'm going to go live now. Hello. I hope everyone is having a pleasant evening. Today, I can't believe it's November. This year is just flying by. It's been very busy with the foundation, and so we are always happy about that. We're also I wanted just to mention a few things about November and why I love November so much. And that's because November is an opportunity for all of us to join in a global movement, and that's Giving Tuesday. This year, Giving Tuesday happens on November 29th. And like I said, it's a unique opportunity for all of us to be part of something. It's a day where all of us can give, not only with kindness, contributions to nonprofit, but also for awareness. And we definitely need that here worldwide and in New Mexico with CKD, the chronic kidney disease. It's a terrible disease that doesn't it hits everyone. I think not there's no one that's not affected one way or another by diabetes or chronic kidney disease. So with that being said, I encourage you to just stay tuned to Facebook because I will be posting things, special little events that we'll be doing, as well as please look at our website. I will be posting things there as well. Our website is nmkidney.org. So with that being said, I want to introduce our speaker, Dr. Romero, and thank you so much for giving up your time. You're very busy, and we appreciate you donating your time and talking about hypertension and chronic kidney disease. I'm very anxious to hear your speech because I have family members that have high blood pressure and diabetes. So this is something that I've looked forward since Dr. Barantes told us you were going to join us for today. So with that being said, I will turn it over to you, Dr. Romero.
All right, thanks. Thanks for having me. I spent some time looking at some of the past presentations, and I know that a lot of you have been educated on, chronic kidney disease. And Dr. Thimisetti recently gave a talk talking about, modern therapy or recent therapies that have come out to help, slow down the progression. When I thought that I would talk about the role or the impact of hypertension on chronic kidney disease and how we should approach it and how we should treat it. I'll start, let's go on. Let me just figure out how to advance this slide. Okay, so I will be talking about the impact of hypertension on chronic kidney disease. I will be talking about some of the goals of therapy. Certainly when we're looking at or addressing hypertension, lifestyle changes play a big role. So I'll talk a bit about that. And then I'll talk about medication treatment options. These are medications that I'm hoping that you all will remember, because I hope that when you see a provider, whether it's a nephrologist or a primary care doctor, and you have high blood pressure, it's okay to ask if you should be on certain medications that we'll discuss today. Because there's certain classes of medications which have truly been shown to slow down the progression of kidney disease. All right, so I know that if you've watched some of the presentations before, as I watched recently, most of you should know that what have known the word or heard of chronic kidney disease, and it is defined as persistent kidney damage accompanied by a reduction in the glomerular filtration rate, and we refer to that as GFR, and people can have proteinuria or they cannot. So I want to stress that most of you should ask your providers what your GFR is based on your blood work. And GFR does, give us some idea of what the kidney function is. And the lower the GFR, the worse the function. So it's always, when you have basic blood work, it's appropriate to ask, for the result of the GFR. Proteinuria refers to whether or not there is protein in the urine. So when we send you to the lab, before you see us in clinic, or when your primary care doctor does, and they ask you for a urine sample, it's one of the things that they're looking for is to see if you have protein in the urine. And why does that matter? Because if you have protein in the urine, that is certainly a marker of chronic kidney disease. And the more protein that somebody has in the urine, it correlates with worse kidney function that can decline quicker. So when we see protein in the urine, we want to see if we can help decrease the protein loss from the kidneys, because that can slow down the progression of chronic kidney disease. Chronic kidney disease does affect at least 13% of the U.S. population. There's a higher, we're seeing a rise in chronic kidney disease, and that's attributed to an aging population that we have, increased incidence of hypertension, diabetes plays a huge role, and then people are unfortunately just not living as healthy, and and obesity is worse, increasing, so that certainly is a risk factor for chronic kidney disease as well. Okay, when people have chronic kidney disease, at least 85% of them will have high blood pressure as well. I will talk about the stages of the CKD in a little bit. Hypertension it results in people developing end-stage kidney disease 30% of the time. So, what ESRD is when people's kidneys, when a patient's kidney function has worsened to the point where they need dialysis support or they need a transplant. And again, 30% of those patients who develop ESRD, it is due to having a long-standing hypertension. We do know that uncontrolled hypertension is associated with a more rapid progression of chronic kidney disease. And there are guidelines that have been available that give us, guidelines that help us, to offer medications and other, things to lower blood pressure and to slow the progression of chronic kidney disease. The reality of it is most patients with chronic kidney disease and hypertension will need at least 3 to 4 different blood pressure medications to control it. All right, a lot of you who have probably seen a slide similar to this. And this shows the stages of kidney disease. Kidney disease is staged into 5 stages. Stage 1 being the most mild, stage 5 is the most advanced. We start to prepare a patient for dialysis when the kidney function is close to stage 5 or at stage 5, or we're getting that person ready for transplant. So certainly our goal is to slow down the progression as early as possible. And one of the ways that we do that is to control blood pressure. Again, like I mentioned during the prior slide, 30% of patients who develop end-stage kidney disease, it is solely due just to hypertension alone. And as a nephrologist, we tend to get patients we get referrals rather from patients that tend to have stage 3 or 4 chronic kidney disease. Occasionally we'll get a stage 2, but the earlier we get to see a patient who is showing evidence of kidney disease, we can do more, to hopefully slow down the progression and just, of the kidney disease in that patient. So we do like early referrals because, there's a lot of studies which have shown that is when a nephrologist gets involved early in chronic kidney disease, the patient tends to have a slower progression in the disease. With chronic kidney disease and hypertension, our goal is to lower the blood pressure to 130/80 or under, and that is in a diabetic or non-diabetic patient with kidney disease. I mentioned earlier that I would talk a bit about lifestyle modification. Weight loss is important when we are trying to improve blood pressure management. People can lose 10 pounds and the blood pressure can drop, 3 to 4 points, just from that. As you all know and have heard of, increased physical activity does improve blood pressure management as well. And there's a lot of data showing that if people, can take part in cardiovascular activity, and that's even just like kind of, walking, brisk walking, at least 5 days a week for 30 minutes, they will, that person will probably have a drop in blood pressure of 5 to 8 points. So, essentially, if their blood pressure was 138, the systolic number, the upper number, with integrating physical activity, they can get it down to 130 just with that alone. And of course, dietary, changes are important. I'll mention some details about a couple of diets that we often will recommend. One is called the DASH diet, and this diet has been shown in studies to lower the blood pressure, by 8 to 14 points when it's followed. And then if some of you come to our office, you've probably also heard about the Mediterranean diet. A lot of our providers have recommended that diet, and I'll have a few details on that as in some other slides. So the DASH diet, this was a study and then a recommendation that came out from the National Institute of Health many years ago. So with this diet, the recommendation is that foods should be, that we take in, it should be limited, there should be, let me just get orange. I'm losing the screen here. Hold on. All right. Okay. All right. You all can see the screen, correct, Leandra?
Yes, sir.
Okay. This diet, you limit foods that are high in sodium, saturated fats, and added sugars. This diet can lower the blood pressure in as little as 2 weeks. The recommendation is that this diet, being what would be considered a low sodium diet, that people should not be consuming more than 2,300 milligrams of sodium per day. We often will recommend to our patients that they should not be consuming no more than 2,000 milligrams of sodium per day. And to give you an idea what that, how much that is, that's roughly the amount of 1 teaspoon of table salt. So, that's for an entire day. And I think, there might be some of you who probably realize that you may be eating a lot more than that. The typical American diet, is at least 3,400 milligrams of sodium per day. So when we, are pushing for 2,300 or even, pushing for 2,000 milligrams, there has to be a lot of adjustments, but we have certainly seen decreases in blood pressure with that change in diet. The DASH diet is rich in vegetables, fruits, and whole grains. It includes, they recommend that people eat fish weekly, they eat poultry weekly, beans are part of the diet, and nuts are fine. And it limits, foods that are high in saturated fats, such as fatty meats or full fat dairy products. So, I'm not going to go into all the details that I have on the slide because I know that some of you all can go back and look at this. It'll be saved. In addition, the DASH diet is, you're available on the internet. You essentially just have to Google DASH diet, and you'll find specifics on it. We also have handouts at our office. So if you all would ever want information that we can send over, please let me know, let Leandra know, and I'd be happy to mail you a bunch of stuff on the diet. But this diet, they do recommend that people consume, 6 to 8 servings of grains. The grain can be some dry cereal. It can be some, rice or pie or pasta or a slice of bread. This is just, again, a recommendation here or an outline of what the diet is. This diet does recommend that people consume 4 to 5 servings of vegetables per day. Fruits are important, and in this diet as well. And they can be whole fruits. They can be frozen, fresh or canned fruits, or fruit juice in the amounts that are listed here. Half a cup. Dairy products, the recommendation is that they should be fat-free or low-fat, and that could be, a cup of low-fat milk or fat-free milk, or low-fat, Greek yogurt, or low-fat cheese. In this diet, they allow for 6 1-ounce servings of, of protein, essentially. So that could be cooked meat, poultry, or fish, or an egg. And these examples here are just considered to be one serving, and again, the recommendation is that people can have up to 6 servings of that per day. It does, the diet also includes nuts, peanut butter, and then for fats, the recommendation is that people, the healthy fat is considered to be olive oil. So that's also one of the main fats that the Mediterranean diet recommends. But there's some other examples here. And when it comes to added sugars, the recommendation is that people should be consuming 5 servings or fewer per week. And that's going to be like, just regular sugar, jelly, jams, sorbet. Again, these are not natural sugars, so, keeping these to 5 or less is what this diet recommends. Again, with this diet, the foods that are recommended are naturally low in sodium. The recommendation was that people can use spices that are salt-free. All the Mrs. Dash seasonings are salt-free. You know, we have lemon pepper, garlic, not garlic salt, but garlic powder, onion powder. Those are all salt-free. Fresh or frozen vegetables are, you know, should be consumed daily. And if fresh or frozen skinless poultry, fish, and lean cuts of meat should be chosen. And, you know, it stresses the importance, and just like, you know, not only in this diet, but in all diets, of reading the labels. You know, I think most of you have been surprised when you actually look at a label, and you can look at the label of canned soup. And I looked at one, you know, this morning, you know, when I was looking over this talk, and, you know, there was this can of soup that I have in my home that has like 900 milligrams of sodium per serving. So essentially, if I had, that small can of soup, it would have counted for at least half of the, almost half of the sodium that I should be taking in an entire day. So, take a look at the, the labels. You know, you're going to be surprised at how much a lot of the products have. You know. Okay, and then we often will recommend the Mediterranean diet. This is, a diet that has very similar recommendations to the DASH diet. So here are some of the benefits. It helps control blood glucose levels. Bone health has been noted to be better. People, brain health seems to improve, and their heart health seems to also improve. So this diet, the basics of it, the recommendation is that natural and processed foods like fruits, vegetables, and whole grains and nuts should be consumed. Olive oil is considered the primary source of a dietary fat with this diet. Reduced consumption or limited consumption of red meat. Fish is recommended to be consumed 2 to 3 times a week. And then on this diet, the recommendation is to keep daily sodium intake to 2,000 milligrams a day at most. All right, and this is a sample of a menu for that someone could follow if they were on the Mediterranean diet. For breakfast, somebody can have some Greek yogurt topped with berries and nuts. They can still have their coffee and tea. Lunch can be with lentil soup, or perhaps some hummus on a pita. A snack could be whole grain crackers and cheese. Dinner, this is where they're throwing in the fish. Again, they're recommending 2 to 3 servings of fish per week, and you can have baked fish with salad with olive oil vinaigrette. And they, this diet, they do recommend, or they do allow for a glass of wine. And it says up to, daily, but, we probably wouldn't recommend that. But, I guess enjoy, some red wine here and there. And dessert, fresh fruit topped with raw honey. That's just an example. All right, so now I'm going to transition. We talked about some lifestyle modification, that can be help with blood pressure management. And now I'm going to talk to us about some of the medications that are available. And these are medications that, that hopefully, most patients with chronic kidney disease are on. And if you're not on these and you have chronic kidney disease, it's okay to ask your provider, as to whether or not you should be on some of these medications. So there's medications that lower blood pressure, and there's also medications that help to reduce proteinuria, and those are considered first-line therapies when we're trying to, when we're treating somebody with chronic kidney disease as well as high blood pressure. There are studies which have shown that there's benefits in using some of these medications, to the kidneys, and also to, it also helps to, prevent, cardiovascular disease. All right, so I'm gonna, I'm not gonna spend too much time on this table, but essentially what I'm gonna do, I probably will come back to this. I think what I first want to do is go over one of the, a class of medications that most people with chronic kidney disease, if not all, should be on. So I'm going to refer to this group, hope maybe some of you have heard of the ACE inhibitors. And then another class of medications, and it has a, it's a, few big words, you can keep it in your head as ARBs, so angiotensin receptor blockers. And these are examples of ACE inhibitors here. Some of you may be on lisinopril, we see enalapril used, these are ramipril, quinapril. So these are all ACE inhibitors. On this side, on the right side, these are the ARBs, also known as the angiotensin receptor blockers. I think the most common one that I see used is losartan. Others are valsartan, candesartan, and olmesartan. So these medications are considered first-line therapy in patients who have chronic kidney disease, especially if they have protein in the urine, because these medications have been shown to help improve blood pressure, but they also help to decrease the amount of protein that somebody is urinating out. And it has been shown in studies that if people have protein in the urine and you're able to lower it with with lifestyle modification with various medications, if you can reduce the amount of protein that somebody has in the urine by 50%, that particular patient is likely to have a progression of kidney disease that is going to be 50% slower than somebody in comparison to somebody who doesn't have who hasn't had an improvement in their protein loss in the urine. So when we see reduction in protein loss in the urine, it certainly the person's probably going to have a better kidney outcome when that's noted. ACE inhibitors, some of you probably heard that not a common, but there's some patients who will have a dry cough, and if that occurs, we often will take them off that medication and transition them to an angiotensin receptor blocker such as losartan or valsartan, and that medication does not have the side effect of a cough, and you still get the benefit of controlling the blood pressure, decreasing the protein loss in the urine, and essentially just in helping to slow the progression of chronic kidney disease. Side effects of this class of medications, there can be the angioedema rarely occurs, but that's when somebody can have swelling of the face, and often includes the eyelids. That person may have to be treated with Benadryl. Sometimes they have to be treated with IV steroids. So it rarely happens, but it's a side effect that has that people do experience from time to time. So again, it's I would like to stress to you all that if you have kidney disease and you have high blood pressure, I'm hoping that you're on one of these medications. If you're not, please ask your provider as to whether or not it would be appropriate for you to be on one of these medications. Okay, that's the list again. I know you can refer back to this later on. Okay, then a lot of our patients with kidney disease retain water, retain fluid, they have edema on their legs, they have on their feet. And we have different classes of diuretics, and these are medications which will essentially stimulate the kidneys to, get rid of extra water and sometimes extra salt. A common groups or classes, we have the thiazide diuretics, and a common one that people are on is hydrochlorothiazide. Another one is chlorthalidone, which is a longer acting medication than hydrochlorothiazide. And then we have the loop diuretics, and the most common one that we tend to use is furosemide, also known as Lasix. There's others in the class, bumetanide and torsemide. These medications are often used to help control blood pressure and to help control and improve the volume status of our patient, because our patients do tend to retain fluid as the kidney function declines. So this is often considered to be a second line therapy for our patients. And there are some studies which have shown that thiazide diuretics seem to do perhaps, if they're be used appropriately, can perhaps slow the progression of chronic kidney disease, and there's improved cardiovascular outcomes as well. So when somebody has stage 1 to 3 chronic kidney disease, that's essentially a GFR of over 30. We will often use a thiazide diuretic, such as hydrochlorothiazide. When the kidney function is less than 30 mLs per minute, certainly that person would have stage 4 or 5 chronic kidney disease. That type of patient, that particular patient tends to respond better to the loop diuretics, furosemide, torsemide. in that, that patient, they tend to, have higher, more volume extra volume. So the loop diuretics tend to work better with, helping to mobilize fluid. So if any of you, develop swelling, and you have kidney problems, it certainly would be appropriate for you to ask your provider if you should be on a diuretic or if you should be on a different diuretic. If you're on a thiazide diuretic, such as hydrochlorothiazide, and your kidney disease has progressed, and now you're doing, a reasonable job, at making sure that you don't, consume, excessive salt. And such, but it may be appropriate at that time to transition to a loop diuretic, such as furosemide, because as kidney disease progresses, sometimes we have to change the diuretic as well. And then we have some patients who are on more than one diuretic. If you're retaining fluid and it's not improving with dietary changes and such, it's always okay to ask your provider if you should be on something different, or even on a diuretic if you're not on one. All right, then there's another class of medications known as the calcium channel blockers. I'm going to go back to this slide that I showed earlier, that table. And these are considered to be pretty much third line therapy when treating patients who have chronic kidney disease and hypertension. And there's different types within that class. So we have what we call our non-dihydropyridine calcium channel blockers. Two common medications in this class are known as diltiazem and verapamil. These medications have been shown to reduce proteinuria either when used alone or when they're added to an ACE inhibitor or an angiotensin receptor blocker, an ACE inhibitor, again, an ARB. And then we have a class of medications, within the calcium channel blocker family, known as the dihydropyridine calcium channel blockers. Amlodipine is a common medication in this class, as well as nifedipine. These medications have not been shown in this, to decrease the protein in the urine, but certainly are pretty effective at controlling blood pressure in a lot of patients. If somebody has protein in the urine and the provider hasn't been able to get it down with with lisinopril, and other changes that they've made, and they can consider adding one of these medications. However, these medications you have to, they can affect the heart rate and such. So you kind of have to look at the big picture. Okay, is this patient's heart function state appropriate for it? Is their heart rate able to handle these medications? So there's a lot that goes into it. But in some people, you're certainly going to get some benefit in decreasing the protein loss in the urine with adding one of these medications. Some of you have probably perhaps had a side effect of edema from amlodipine. So that's I think that being the most common side effect that people have with that class of medication there. Let's see, I went too far. And then we have another class of medications known as the aldosterone antagonists. These are also, diuretics. A common one is spironolactone, also known as aldactone. And this is this class of medications has been shown to reduce proteinuria when it's added for therapy with an ACE inhibitor as well as or angiotensin receptor blocker. And this is added when blood pressure control has not been achieved with first and second line therapies. A side effect of this medication is elevated potassium levels. So a lot of you, hopefully have been educated on, on the possibility of people developing elevated potassium when they have chronic kidney disease, and as kidney function declines, it's more likely to happen. So when we start people on this class of medications, we certainly have to be monitoring their potassium levels and making, if the potassium levels are mildly elevated, we would certainly be educating that patient to adhere better, to the low potassium diet. And fortunately, now that we do have medications that are very effective at bringing down potassium levels when we haven't been able to control it with just dietary modification and such. So it used to be years ago that if a patient had persistent high potassium, And we couldn't get it down with dietary modification or with using, furosemide, which will help, to cause the kidney to eliminate more potassium. Sometimes we'd have to take patients off of lisinopril, the ACE inhibitor, because a side effect of that class of medications is hyperpotassium. But now there's new medications on the market that have been available for a few years. One of them is called Veltessa, and the other one is called Lokelma. And these medications have been helpful in helping to decrease the potassium that somebody has. So now where I'm going with this is that now we can continue to often get the benefit of the ACE inhibitors, such as lisinopril or losartan, or actually let me take that back, such as lisinopril, because that's an ACE inhibitor. Losartan isn't associated with as much, it's not as much of an issue with hypotassium, but still can cause that. So now we can continue most of our patients on an ACE inhibitor or an angiotensin receptor blocker and get the benefits of protecting the kidneys, decreasing the protein loss, while being able to control the potassium levels with medications which have been available for the last few years. All right, and then a lot of you may be on beta blockers. The most common beta blocker that we tend to use is metoprolol. Another name is Toprol XL, the brand name. Lopressor is another name. Other names are atenolol, carvedilol, also known as Coreg. There's limited data that this class of medications, helps, to slow down the progression of chronic kidney disease or proteinuria. But they often are considered second or third line therapies if a patient has heart problems, such as coronary artery disease or congestive heart failure. All right, so in summary, hypertension affects at least 85% of patients with chronic kidney disease. The goals of therapy are to achieve appropriate blood pressure control and also decrease proteinuria. Most patients will require 3 to 4 medications to enable to achieve these goals. And in I can't say enough about lifestyle modification. That has a huge role in slowing down the progression of chronic kidney disease, as well as in controlling blood pressure. So again, if you have high blood pressure, and it's not a goal of 130/80 and under, and you have chronic kidney disease, it's continue to record these blood pressure readings that you're taking at home. Show them to your provider. If you're not an ACE inhibitor or an angiotensin receptor blocker, ask your provider if you should be on one. And if you're not on, perhaps not everybody can be on one, but certainly you need an explanation for that. If you're retaining fluid, inquire about diuretic therapy. Should the common diuretics are the thiazide diuretics or the loop diuretics. So inquire if you should have a change to that if your swelling is not improving with the diuretic therapy that you're on. It's again important for you to know what your GFR is. So every time that you have lab work done, make sure that you look at the GFR in your lab report or ask your provider. And ask your provider if you're noted to have, if you have protein in the urine. You should be able to see that on your urine studies if you look at those results yourself. But certainly your provider should be able to give you a better explanation as to whether or not it's there and how severe it is, and whether or not it's improving with therapy. And just I find that the patients who tend to do better are the patients that are more involved in their health. They're asking me questions about if should they be on this, should they not be on this, and it's chronic kidney disease is a very serious health problem, and the last thing we want to do is declare somebody having end-stage renal disease and put them on dialysis because that's a life-changing event. And so we certainly want to do what we can to protect the kidney function, to at a minimum stabilize it and to slow the progression, and to sometimes with interventions we're able to help somebody's kidney function actually improve at least for a short time. So that was my talk. I hope this has given you some information that will be useful. And if I can take any questions now that you may have.
Okay, well, while we wait for those, I just want to say, wow, what a wonderful presentation. I really appreciate it because I think sometimes when I go to the doctor, I'm a question. I'll do my research and I'm one of those people, but my mom tends to be a little timid when it comes to going to your provider, and you just sit back and but I really appreciated how you brought that out multiple times about asking your provider, talking. It's a relationship
Mhm.
that you really need to have an open relationship with because that's the only way you're going to be able to take control of your health.
That's
Um,
correct.
and I really I appreciated. I did not know the Cinepril. I had I'm a caretaker for someone, and they were having problems with their potassium,
Mhm.
and they were on the Cinepril. And when you said that, like a light just went off, and I was like, that's what happened. And they had to adjust their medications. So
Yeah,
I appreciated that too. It was a little light bulb went on above my head when you said that. But and
exactly.
I can't thank you enough for the lifestyle changes.
Yeah, right, right. We
I'm
push
sorry,
that and
doctor,
push
what were you
that, and
saying?
yeah, we that's that lifestyle changes, modification play a huge role in in our health and blood pressure management and chronic kidney disease. So, we can't reinforce that enough.
Yeah, it was amazing. And you were saying just 10 pounds.
Yeah,
That can really make a huge difference in where you are, especially if you're just at that borderline of blood pressure. If you can just, you lose the 10 pounds, that can bring you down. So that was a wonderful point. I actually wrote that down on my day reminder to remind me to stay on my healthy eating. So
exactly.
thank you
Right.
so
Yeah,
much.
sure.
Thank you. Well, it looks like there's no questions at this time, but if you do have questions for Dr. Romero, if you're thinking and you're like, I should have asked, please email me. And that's info@nmkidney.org. And I can always forward it to Dr. Romero and we can answer your questions. And again, thank you, Dr. Romero, for
Sure thing.
giving of your
Yeah.
time.
No problem. I'm
And
glad to be able to do this. And like I said, if any of you need more specific information or more detailed information on the DASH diet, on the Mediterranean diet, please reach out to Leandra. She'll reach out to me, and I'd be happy to send you some information, through email or through the mail. And so we have plenty of handouts that we can send and may be beneficial. So please reach out so we can help.
well, thank you so much,
All right.
Dr. Romero, and thank you everyone for joining us for November's episode of Kidney Talk, and we'll see you in December. Thank you, Dr.
All
Romero.
right.
Thank you
Thanks.
so
Bye
much.
bye. Right. Good night.